very much looking forward to the presentation from Kate Sapra, who's to my right. Kate is the Director of the Division of Allpayer Models at the CMS Innovation Center. She's the Program Officer for Maryland's Total Cost of Care Model. She has, in her previous background, a lot of research and academic work in the area of public health, reproductive health, and other areas. She is going to be sharing with us the vision of where the CMS Innovation Center wants to now take payment reform and value. She will have some comments to offer around Maryland's total cost of care model and what we know about that, and kind of a little bit about the future of that. We're really privileged to have somebody who's a leader at the Innovation Center and CMS to give comments and content to us today. Without further ado, let me invite Kate to join the podium, and the floor is yours.
Good afternoon. I'm super excited to be here with all of you today. I have a very long history with the Maryland model. I've been involved with it since 2018 in a very intimate way. So it's great to see some familiar faces, and really looking forward to sharing with you the opportunity that Maryland has with the new strategic direction that CMMI is taking. So for those of you who are less familiar with the Innovation Center, we were created under the Affordable Care Act. And our statute states that the purpose of the center is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to Medicare and Medicaid beneficiaries. And that dual emphasis on savings and quality is very important as we think about what success looks like under these alternative payment models. So there are 3 scenarios for success. Quality improves while cost remains neutral. Quality is neutral while costs decrease. Or in a best case scenario, quality improves while costs decrease. And so again, keeping in mind that dual nature as we think about success. CMS now has 10 years of experience under CMMI, and we have learned a lot over that time. We have launched over 50 alternative payment models, and yet only 6 of them have achieved statistically significant savings and quality improvement. And only 4 of them have been certified for national expansion. And those are the ones that are here in bold. Now, you'll note that the Maryland all-payer model did achieve statistically significant savings and quality improvement, but hasn't been expanded. And the reason for that is that the all-payer model, when the contract between CMS and the state of Maryland was signed, stipulated that there would be a successor model, and that model would focus on total cost of care. The all-payer model did a tremendous job of focusing on hospital cost and quality, but we all knew from the beginning we needed to go beyond that. And so the all-payer model laid the foundation for the total cost of care model. And so as we think about the past 10 years at the Innovation Center, we're really reflecting on the progression of alternative payment models, both in terms of the participant and patient experience, but also thinking about how we can move providers along the risk continuum while continuing to put the patient at the center of everything we do. And so the early model tests at CMS in general were about enhanced and integrated care coordination with limited financial risk. Now, I will say the all-payer model had certainly full financial risk from the beginning, but we are still progressing again in Maryland as we move towards total cost of care. And other models in the center have that same type of progression, where we are focusing really on total cost of care now and improving quality while integrating both clinical treatment and addressing health-related social needs. So I assume most of you are familiar with the results of the Allpayer model, but I thought it would be helpful to share CMS's perspective on the successes under the Maryland Allpayer model. And we have an independent evaluation that's conducted for each of our models, and we found $800 million in hospital savings, which is quite impressive. And so when we look also at quality, which I mentioned is the other part of our statute, we did see significant declines in hospital admissions for ambulatory care sensitive conditions and significant reductions in readmissions. So certainly in terms of improving quality and cost in hospitals in Maryland, the Allpayer model was a success. And so the total cost of care model is building on that foundation. And so hospital global budgets remain a critical part of the total cost of care model, but now we have provided the state with more tools to enhance care coordination across settings and to really provide the incentives to get everyone rowing in the same direction. And again, I assume that most of you are familiar with the total cost of care model, but for those of you that are less familiar, these again are the tools to achieve those total cost of care savings as well as the quality improvements that CMS seeks. The hospital global budgets, again, are full risk. We have the Care Redesign Program, which includes the Episode Care Improvement Program and the newly launched Episode Quality Improvement Program for specialists, and then the Maryland Primary Care Program. So again, we're thinking about how do we keep people healthy and out of the hospital? When people do need a hospital, how do we improve the quality of care delivered there? And then how do we ensure that there are smooth transitions in that post-hospitalization experience, which we know is a particularly vulnerable time for Medicare beneficiaries? So from CMS's perspective, there are certainly benefits of the total cost of care model relative to the all-payer model. And again, it is around adding those new provider types into our care transformation efforts so that we really do have a patient-centered experience of care, linking disparate providers to create that more patient-centered care experience, and aligning incentives. And again, this emphasis on total cost of care rather than just hospital savings. So now that we've looked back over the past 10 years and also reflected on Maryland's progression during that time, what's coming next for the Innovation Center? Well, last fall, CMMI published a white paper that outlined our vision for the next 10 years. And that is a health system that achieves equitable outcomes through high-quality, affordable, person-centered care. And there are 5 pillars to help us achieve that: driving accountable care, advancing health equity, supporting innovation, addressing affordability, and partnering to achieve system transformation. And I'll go into each of these in a bit more depth. So when we think about driving accountable care, the goal of that is to increase the number of beneficiaries in a care relationship with accountability for quality and total cost of care. And when we think about Maryland, there are a number of layers of accountability for cost and quality. In its contract with CMS, the state has taken on responsibility for total cost of care for all Medicare beneficiaries in the state of Maryland, as well as the quality of care they receive, and has also committed to population health improvements under the statewide Integrated Health Improvement Strategy, or SIHIS, which is a mouthful but is a very ambitious population health program. And then we also have, of course, provider level risk and accountability for cost and quality. And here I want to specifically note for the hospital global budgets, the Medicare performance adjustment is a critical piece. And the MPA assigns all beneficiaries in the state of Maryland to a hospital that is then accountable for cost and quality. This is a huge shift in terms of what happened under the Allpayer model and what's happening under the total cost of care model. This is really where that accountability comes in for hospitals. And CMS sees this as really critical. We also have primary care providers taking accountability for cost and quality. And so I also want to draw your attention to the fact that CMS is thinking not only about Medicare beneficiaries, but really wanting to draw those Medicaid beneficiaries into our care transformation efforts as well. The second pillar is advancing health equity. And the goal here is to embed health equity in every aspect of innovation center models and increase the focus on underserved populations. And here, I think Maryland has actually been a pioneer and is sharing a lot of lessons learned with the CMS Innovation Center. And so a few places that I specifically want to call out. Federally qualified health centers have been participating in the Maryland Primary Care Program since 2021. That's the first time FQHCs have participated in a CMS Innovation Center model, so a really big deal. Also, Maryland primary care practices will be addressing health-related social needs through new heart payments that are available this year. Also, I want to note that the hospital quality program in Maryland has been very ambitious in setting incentives to reduce disparities in readmissions, and also under the statewide integrated health improvement strategy, reducing disparities in maternal morbidity and mortality. And we were very excited last summer when the legislature authorized over $70 million in support of that effort. Also, as we think about advancing health equity, we have to have Medicaid as part of that conversation. And so we're really excited to continue engaging with our Maryland Medicaid partners to bring them into the fold in the Maryland Primary Care Program. The third pillar to achieve our vision is supporting care innovations. And there, our goal is to leverage a range of supports that enable integrated, person-centered care. And some of the targets for measuring progress on this are really around patient experience of care. And I know that hospitals in Maryland have been trying really hard to improve the patient experience of care throughout the Allpayer model and also under the total cost of care model. And so we're really excited to see that continued effort. Also, primary care practices have an opportunity to continue improving the patient experience of care. The fourth pillar is improve access by addressing affordability. And the goal is to pursue strategies to address healthcare prices, affordability, and reduce unnecessary or duplicative care. And so here, of course, we have the Allpayer global budgets. But the total cost of care model, again, provides this focus on providing the right care in the right place at the right time through the Maryland Primary Care Program, the Care Redesign Program, and the Hospital Payment Program. And so every time we're able to avoid an unnecessary hospitalization, payers and patients alike see both the quality and cost benefit of that. And so again, just really want to encourage Maryland to invest in improving that patient experience of care, which includes focusing on prevention and reducing unnecessary utilization to ensure that healthcare remains affordable. And then the fifth pillar is, again, one that's not new to any of us here, partnering to achieve health system transformation. And so the goal is to align priorities and policies across CMS, payers, purchasers, states, and beneficiaries to improve quality, achieve equitable outcomes, and reduce healthcare costs. And so we have a very long history at CMS of partnering with the state of Maryland. And the hospital global budgets, of course, are a place where all payers are at the table. The Maryland Primary Care Program is another place where there's a lot of opportunity for alignment. And Care First, the predominant commercial payer in the state, has been aligned with the primary care program for the past 2 years. And then as we think about episodes of care in the Episode Quality Improvement Program, again, the state was really intentional in aligning those episodes for Medicare beneficiaries with those for commercial patients, so that for providers, it is a more rational business decision to transform the way they deliver care. And again, as we take a big step back and we think about people that receive care, throughout our lifetimes, we are likely to have a number of different payers paying for our care, but we may continue to see the same provider throughout our lifetimes. And regardless of who the payer is, we want to make sure that someone is accountable for the cost and quality of our care so that we can afford it, we can have access to high quality care. And so for those of you who want to learn a bit more about the Innovation Center and where we're going, you can get our white paper on the strategy refresh on our website. The Maryland evaluation reports are also there. You can subscribe for regular email updates, and you can follow us on Twitter. So with that, I think I will close, and I'm looking forward to our conversation.
Thank you, Kate. So let me just give you a little preview of the next 15, 20 minutes. I was going to ask Kate 2 or 3 questions and then open it up to all of you. I suspect there's interest in the room, but I did want to start. And Kate, one of the first questions I have is, to what extent is the Maryland model, the total cost of care model, and whatever the future version of that would be, how well does it currently align to those high-level objectives that you laid out? Are there areas where there's going to need to be some modification to fit inside of the newly published CMMI objectives, or is it largely already aligned to those objectives? And I'm looking for a little bit of almost like a gap analysis between what the model looks like now and how it might be viewed as whether it fits within those principles you laid out.
Yeah. And that is a place where we're continuing to have conversations with our state partners. I think one of the real benefits of the long history of CMS partnering with the state is we truly do have phenomenal relationships with our state partners. And so we are actively every week talking with our state partners about how they can better align. And there are places that I called out certainly around health equity where Maryland is leading. And I would say, don't take your foot off the gas, because that's certainly going to become a place of increased focus and attention. When I think about opportunities in Maryland, I think they're really around engaging Medicaid. Again, we're working with them right now, but want to continue to develop those relationships because the accountable care is about both Medicare and Medicaid beneficiaries. And so really ensuring that they have the same opportunity to access the care tools that we're providing to providers for Medicare beneficiaries. And then also, as I think about accountable care, as I mentioned, the Medicare performance adjustment has been really critical as we've been thinking about how closely Maryland aligns with CMMI's definition of accountable care. And it's, again, that someone is a provider, not a plan, but a provider, is accountable for cost and quality. And so I think without the Medicare performance adjustment, it would be a lot harder to think about the hospital global budgets fitting within that accountable care relationship. So I know HSCRC has undertaken a lot of work with the MPA. CMS has provided a lot of guidance around it too. But I do think that's a critical piece. In addition, in the primary care program, continuing to have that accountability for total cost of care and quality. And I guess that'll bring me to my last point on quality, where CMS really wants to continue to see those quality improvements. And it's not just about hospitals anymore. Certainly, we want to see patient experience of care improve. We want to continue to see the gains that were made under the Allpayer model with respect to readmissions and potentially avoidable utilization continue to trend in the right direction. But we also want to make sure that population health improvement is being realized as well. Again, the total cost of care model spans the entire care continuum. The state has invested a lot in the statewide integrated health improvement strategy, and we're excited to see the outcomes of those efforts. So certainly I think Maryland is on the right track. We all have more work to do, but we're really excited about the opportunities here in Maryland, leveraging lessons learned across the Innovation Center and making sure that, again, all Marylanders, and I'm a Marylander, have the benefit of these care innovations.
And let me just preface this because I know that there are some areas of the questions that you're just not at liberty to disclose because negotiations are ongoing. You've mentioned Medicaid a couple of different times. To the extent you're in a position to answer this question, is the Innovation Center expecting to see, as the new renewal discussions occur for the total cost of care model, are you expecting to see more engagement or involvement of Medicaid as part of that? Is that, am I interpreting you correctly that that is going to be an explicit expectation as those conversations proceed?
Yes, and it's not just in Maryland, it is across all of our models. Again, if we're going to achieve this goal of having the vast majority of Medicaid beneficiaries in an accountable care relationship, it has to be all of our models. And I think, again, Maryland and other state-based models certainly have a leg up, but all of our models are going to need to have this really close Medicaid alignment with our care delivery tools, with our financial incentives, with quality metrics, again, to make sure that everyone benefits. We are the Center for Medicare and Medicaid Innovation, and we want to make sure that our most vulnerable beneficiaries are not left out.
One of your slides early on, I think it was slide 3, mentioned that of all of the innovation demos that have been done, 6 have been proven to be successful in a statistical way. 4 of those you had in bold that were amenable to replication. 2 of those, including Maryland, were not indicated as amenable to replication. Is that really a byproduct of the model here being so deeply ingrained in Maryland, or is there still the possibility that that kind of Maryland approach could be replicated in other states? Because from time to time, other states send delegations here, they want to learn more, they evaluate whether it could work in their markets. And I'm curious how to interpret the indicator on that slide that Maryland, unlike some of the others, wasn't initially defined to be a replicable model.
Yeah, so I think there are 2 answers to that. One is, or the most immediate answer is, as I noted, the Allpayer model always envisioned a successor model. It was literally written into the contract between CMS and Maryland. So we always knew a total cost of care model would be the outcome of the Allpayer model. And then as we think about lessons learned, we actually fairly recently published in JAMA Health Forum an article on exportable lessons learned from the Maryland model. Austin Killaroo, who's a researcher at the University of Pennsylvania, was the lead author on that. Highly encourage you to take a look so that when people ask you, what is portable, you have some answers. Part of it is around the close relationship that CMS and the state had, which I mentioned. Another part of it is the really, really close communication that Maryland stakeholders have. And I see folks from MHA here, which has played a really key role, but HSCRC as well, even if providers don't always like to hear what HSCRC has to say, it was noted in the paper that at least that communication was very transparent. I think setting achievable goals that were ambitious but certainly achievable was also important. And there are a number of other lessons learned. I also would like to shout out CRISP. I don't know if anyone from CRISP is here, but Maryland really benefits from that health information exchange.
Somebody wave.
Oh, hey, Craig, you look very tan. So that was another one that got called out because it really is a very rich resource that Maryland has. So there are certainly lessons to be learned. And as I said, certain parts of Maryland are being exported. So we led the way. And I say we because I really have had my hands in the Maryland model for a long time. But we engaged FQHCs in an APM, and now across the center, we're looking to see how we can replicate that nationwide. The Health Equity Advancement Resource and Transformation, or HART payments, first of its kind payments based on the clinical and social complexity of patients so that primary care practices can address their health-related social needs. Again, there's lots that the Innovation Center wants to learn from this pilot. So I would say I wouldn't read anything into the fact that the Allpayer model wasn't expanded. And certainly there are lessons to be learned that we are sharing right now.
Okay, I have one final question, and then we will give you all a shot at this. The final question is really, what are you at liberty to tell us about the status of the negotiations, the timeline of the process, kind of where this is going toward renewal, and anything you can share that you're allowed to share. I'm sure there's curiosity about where it stands, how quickly it might get to a renewal stage, and where we are.
Yeah, it's hard to believe that we're already in year 4 of an 8-year model. Again, I was at the State House when the governor and the administrator signed, and it felt like an 8-year model was such a long model, and so it's hard to believe that we're already halfway through. Again, the contract between CMS and Maryland lays out really clear timelines, which is helpful for all of us in terms of setting expectations. So by the end of 2024, CMS must make a determination on whether it will expand the Maryland total cost of care model as is. And as we consider that decision, we must take into account the independent evaluation on cost and quality outcomes. We're also going to be considering how does the Maryland total cost of care model fit into the broader CMMI strategic vision, which I shared with you today. And if CMS decides not to expand the model, then the state can propose a new model test by the end of 2025. So we certainly have clear steps outlined for us.
Thank you. Let me open it up. I'm guessing there's interest in this topic. Would anybody like to ask questions of Kate? Random Nicole Stallings person.
Thank you, Chuck, and thank you, Kate. Pardon me.
By the way, there's 2 microphones that will be run around the room to enable these questions. Nicole.
So first I want to say, Kate, thank you to you and your team for everything that you've done over the years to see our model evolve. I actually want to take Chuck's question and flip it a bit to say, what are the other models nationally where we should perhaps think about exporting components? National models or demonstrations you see in other states?
That's an excellent question. And I hate to continue picking on Medicaid, but I will say as I look across my portfolio, so the Division of All-Payer Models houses all of the state-based multi-payer models, which includes Maryland, the Vermont All-Payer ACO, the Pennsylvania Allpayer Rural Health Model, and then CHART, which is the Community Health Access and Rural Transformation Model, which just launched in 4 states: Washington, Alabama, South Dakota, and Texas. So we're really excited about that. And there, Medicaid is required to be at the table, and Medicaid certainly is in the hospital global budgets, but we'd like to see greater involvement there. We also, you're going to continue to see more and more requirements around health equity. And some of that was laid out in the slide, and our Chief Medical Officer, Dora Hughes, recently published, I believe it's in Health Affairs, a blog on CMMI's health equity strategy. ACO REACH is really the first model that's come out of this administration. And there we see requirements around collecting demographic data and stratifying quality measures by certain demographic measures. So that's a place where we're going to be looking. Having real investments in addressing health-related social needs and improving health equity. I've pointed a lot at the Maryland Primary Care Program, and I know there are a lot more opportunities in the state of Maryland. So again, hospitals have had really strong incentives under the global budgets to reduce potentially avoidable utilization, and now with the incentive to reduce disparities in readmissions, again, I think very much on the right track, but I would be redoubling my efforts to reduce inequities in the state. So I think I'll leave it there because that's certainly plenty. And I guess I can't help myself. Last one, accountable care. And I've already talked about this, and I'm just, someone who keeps to my speaker training of like hopping around my 3 islands, but like Medicaid, health equity, accountable care. But truly, the Medicare performance adjustment has been really critical as we think about the thousands of Medicare beneficiaries and Medicaid beneficiaries in Maryland having access to accountable care. The MPA has been really critical. And so that's a tool that I think is going to be really important going forward. And so it has made, I think, a lot of progress. But I will be continuing to make sure that that remains a critical part moving forward.
Thank you. Other questions? We've got one in the corner here.
I'm Tim Adelman from, whoa, that's loud. Tim Adelman from Luminous Health. I'm curious how CMMI is going to normalize its data to assess performance, because 2019 as a baseline is gone. It doesn't exist moving forward for many organizations with our cost structures and the care delivery. And over the past 2 years, we have such fluctuations in the way care was given and demanded by the population. So I'm curious, as you look at the models and you're going to assess performance, how do you normalize that data to be able to compare apples to apples versus seeing these mass fluctuations? And for many of us, I'm assuming we're looking at still another 24 months at least to get to a new normal, whatever that is going to be.
So I think there are a couple of ways to interpret your question. One is in the what we've typically called the actuarial performance of the model, and the total cost of care model right now uses 2013 as a baseline when we think about savings. So certainly not impacted by COVID in that way. And then the other way to think about it is with respect to the independent evaluations. And so again, all CMS models have to have an independent evaluation to assess cost and quality, and those always use a comparison group. And so there certainly are a lot of questions for the folks on our evaluation team about how to construct valid comparisons. And certainly there are parts of the US that have been hit harder by COVID-19 than others, but unfortunately no part of the US has been spared. And so part of our work moving forward is going to be thinking about what those baselines should be and how are we going to establish a new normal for those baselines. And I think it's going to be an iterative process. And so that's certainly something to look at as we move forward. I'm very curious to see what the evaluation results are going to look like for 2020. Those will be the first set that we're going to get from COVID-19. So again, would just encourage everyone to stay tuned to our Twitter and our website. We do push out a lot of information.
Thank you. Other questions? Going once? Okay, we have one up here. Is that, I'm not sure which one you're going to, Shelby, but we've gotten one toward the front as well.
Okay. Hi, I'm Carol Robinson. My consulting firm, Cedar Bridge Group, based in Oregon, so a lot of my professional experience prior to doing that was working with Oregon Health Authority on our state waiver, which has its pluses and minuses, like many. But one of our experiences as a firm was to work with Intel for 4 years on an employer-sponsored value-based payment model, essentially ACO model. And they did a few things, but one of the things they did, which I'm not necessarily seeing in the federal regs or advice, but going to the shout out to CRISP, actually requiring data to be shared in care transitions and then referral information to come back to the referring provider had huge impacts on the results for Intel's employees in their connected care program. And we wrote about this in a white paper that was published, I think, in 2018. But there's, are there any kind of levers like that you're considering, to kind of go with the 21st Century Cures requirements and patients' right to access data? I'm just curious.
Yeah, certainly access to healthcare data is a critical part of making all of this work for all of us, right? Not just payers, but patients as well. And so this is a place where there is a lot of work being done. And as I start talking about health equity and that integration of health and social needs, we're working on it. At CMMI, this is a place where we're trying to see exactly how far we can carry the water by ourselves, how much we can engage other partners like ONC to help us, because I do think it is a critical piece as we, again, are investing in addressing health-related social needs. How do we actually go about closing that social needs loop? And so that, in addition to trying to close the healthcare loop, and yet, I exist as one person. I am not like a social needs Kate and a medical needs Kate. I'm just Kate. And again, as we're taking this more patient-centered approach, we are thinking about how to make sure data is shared as widely as is appropriate, given not only privacy laws, but our concern for individuals' privacy, because we know it contains a lot of sensitive information. So that is my way of saying we are working on it, and stay tuned. I hope we have a lot more to come.
Thank you. And I think this will need to be our last question so we can get to the next session.
Hi, I'm Diane Garretts, an independent consultant in the state. I'm just curious, I wanted to find out what authority you're actually approving the Maryland total cost of care under, and just so I can follow up and know what the cycle of approval is. Is it 1115 Big A, as I like to call it?
Little A.
It's a little A.
Big A. No, you're right. 1115 Big A. The little A's are first.
Okay,
Yes.
yeah.
Our entire authorizing statute is 1115A, and it includes all the provisions that for expansion, including the role of the chief actuary of CMS and the secretary's role as well. And it's written in fairly plain language, I think.
Okay. All right. Thanks. Appreciate that.
The one thing I can add to that is Maryland's initial hospital waiver was approved in 1983, Senator Mikulski was key to that. That was when Medicare was moving to DRGs. Maryland didn't want to lose its unique all-payer model. But when the state moved toward the 2014 demonstration that Kate referenced earlier, the state signed an agreement with CMS, basically foregoing its grandfathering under that Social Security Act provision and converting into this new waiver model with periodic renewals. So the old 1983 statutory Social Security Act grandfathering no longer exists, and we're now in this world of waiver renewals and waiver conditions. Let me ask you all to join me in thanking Kate for her presentation.